Thank you, ma'am. Thank you for the introduction.
Santosh, you can upload.
Yes, sir. Can see my screen, sir?
Yeah. Please carry on.
Yeah. Good evening, all. At the outset, I'd like to thank AIOS and Dr. Partha for this opportunity. I'll be talking on cataract with presenting with moderate NPDR and CSME. So this is about a 59-year-old gentleman who presented with the complaints of blurring of vision in both eyes for 2 months. Coming to his systemic issues, he was a type 2 diabetic patient with normotensive on treatment with insulin for 7 years, but he had fluctuating blood sugar levels of HbA1c of 7.5 with normal lipids and hemoglobin. He did have a diabetic foot ulcer, which was healing. The vision in right eye was 618 and left eye was 612 with NS1 to 2 cataract in both the eyes. So since the cataract was not very significant, the major issue was the moderate NPDR with CSME. I don't have a fundus photo of this patient, but since he presented with fluctuating blood sugars and healing foot ulcer, to rule out PDR, I had advised FFA, which showed delayed arm retina time of 24 seconds and NPDR changes in both eyes with CNPs and a distorted FAZ. OCT showed a mixed macular edema with cystoid changes as well as subretinal fluids and intraretinal hard exudates in both eyes, left eye more than the right eye. So this was a presentation, and post one injection of ranibizumab 1 month later, there was a good resolution of macular edema with intraretinal hard exudates still present, with a good improvement of vision up to 6-9 parts in both eyes. The patient was again seen after one more ranibizumab. After 2 months, the edema in the right eye was much better with some amount of hard exudates, wherein in the left eye, there was a recurrence of macular edema with CME as well as SRF. So after that, the patient was lost for follow-up for 5 months, wherein the macular edema had recurred, mostly CME with spongy thickening and intraretinal hard exudates in the right eye. Whereas in the left eye, there was subretinal fluid also that had come up. So since there was recurrent macular edema, I went ahead with Ozurdex and a modified grid in both eyes. 3 months later, we could see the foveal hard exudates, the hard exudates which were there, they started migrating towards the fovea, but the vision maintained at 6-12 parts, whereas in the left eye, the cystoid macular edema persisted with the SRF coming down, whereas the hard exudates also started kind of accumulating. So there were multiple injections, Ozurdex and again modified grid, which was done over the next 1 year. But the patient was lost for follow-up for 4 months after the latest both eye Ozurdex, and BCVA dropped with advancing cataract. So when we saw him 4 months post both eye Ozurdex, we saw that the vision in the right eye dropped to 624 and in the left eye dropped to 660, with cataract increasing to NS3 with PSC in the left eye. So in the right eye, again, there was a cystoid edema, left eye, again, cystoid edema with lots of HRDs, the hyperreflective dots. So I advised both eyes cataract surgery 2 weeks apart with concurrent IVTA. IVTA was given at the same time of cataract surgery. So this is a fundus photo post 1 month cataract surgery with IVTA. Vision in the right eye improved to 6.9 and 6.12 in the left eye. We can see the Ozurdex implants, which is degrading. So edema had significantly reduced in both eyes, but there are some amount of intraretinal hard exudates and HRDs. 3 months post cataract surgery, maybe the Ozurdex got absorbed. Then there was a bilateral recurrent macular edema which happened, and the right eye PDR, the diabetic retinopathy progressed to PDR, which was confirmed on FA. And there was dropped vision again in both eyes. So this time there was SRF that had formed in both eyes with again HRDs and SRF even over here. So 1 month post both eyes Ozurdex, the response was not the same. I mean, even after right eye PRP. So this time the resolution of edema took time. 1 month post Ozurdex, SRF came down a little bit, but HRDs persisted. And we can see the changes in the architecture of the macular layers also. We can see that there is drill-like changes and changes in the outer retina as well. So this is the latest follow-up in August 2020. This is the review of 5 months post Ozurdex, and vision in the right eye was maintained at 612 and 636 in the left eye. SRF again increased in the right eye and the cystoid edema, and this time ERM started forming. So coming to systemic status, his diabetes was still uncontrolled with the HbA1c of 8.8, and this time he developed hypertension in the meanwhile, and diabetic nephropathy, creatinine was 2.8, and again diabetic foot ulcer, which was there for 6 weeks, hemoglobin was 12. So this was a diagnosis, and Macular edema treatment still continues. I had advised FA and intravitreal injections after physician clearance in view of nephropathy as well as the foot ulcer. So to summarize, we do kind of see many macular edemas, especially CSMEs, simple spongy thickening and all, which are amenable for focal laser, modified grid, or centrally involving DME where few injections are required. But this case especially highlights the advancing diabetic retinopathy with recurring bilateral diabetic macular persisting even after cataract surgery. So a brief history roundup, wherein it's a 59-year-old gentleman with type 2 diabetes, started as a moderate NPDA with CSME and cataract. Cataract and diabetic retinopathy advanced with time and treatment when we advised both as cataract surgery as well as a concurrent IVTA. Advanced systemic conditions also advanced over a period of 3 years. And there was corresponding retinal layer damage to the inner and outer layers. So we need to kind of watch out for these changes for a period of time, which can lead to poor visual outcomes in recurrent macular edema. Thank you.
Thank you,
for letting me.
Santosh, for a nicely worked up patient and long follow-up and follow-up with documentation. That is what is very impressive about your case, that you have follow-up with photographs of every follow-up. I think this case just highlights, you see, patient was lost to follow-up at least multiple times, 5 months and again
Yes.
a lot of time. Because what Giri had initially said, and a lot of people also agreed, that the importance of metabolic control and counseling, the need to tell for regular follow-up is very, very significant. Because if patient loses follow-up, then rebound edema, then ultimately, drill and ERM, everything starts. Metabolic control also is good. So I'll request Dr. Kim and Dr. Pramod Dhande to take the lead in discussing this case.
Thank you, Dr.
Yeah, Kim.
Yeah, thank you, Dr. Lalit. And that's a very good presentation, actually, for Dr. Santosh with the well-documented images. I should congratulate him on that. Patient showed a moderate NPDA when he presented, but subsequently he improved, and then again he was going down. It's very typical of these patients, especially when we see over a long period of time, how these patients, when they get to, when they're lost to follow-up, you tend to see these changes happening more frequently. One important thing, even in the second and third visit, I was just looking at the OCT when he was talking about the hyperreflective spots. It seemed to show even in the third visit, there was a ring of like this pearl necklace sign. That kind of indicates that these patients are going to worsen over a period of time, in spite of repeated follow-ups, and more so that these patients should be seen more frequently than probably every month or something. But I think over a period of time, you did the course. I would have done exactly what Dr. Santosh had done in the periods that the patient visited, especially switching over to Ozurdex in those cases.
Pramod?
Yeah, I totally agree with Dr. Kim. Exactly, probably I would have done same course. But when I look at it at the 3-month follow-up post Ozurdex, and as we know, like though 4 months, 5 months, 6 months, but I would have just more or less the moment start bouncing back. I think after 3 months, I would have still, that time itself, I would have suggested go ahead with another Ozurdex probably in that in both eyes. So, but I think that's an inherent issue we have. Follow-up issues are there. It's beyond anybody's control. And whatever he was doing, I think is the right way, right approach what he had.
Rosha, what is your threshold for shifting to steroid after injection? 3 injections, 6 injections, or what is your protocol?
Very good case, very good presentation. This kind of patients is like we facing here in Brazil. That's, well, the patient has very bad control of diabetic and hypertension, and the follow-up is not easy because the patient not keeping coming every month. And I think the doctors did the very good job with the case. And if you see, the patients respond well at first with the injections, but because they lost follow-up, they come worse and worse and have to inject Ozurdex. Here in Brazil, my practice based on the trials, I keep doing 6 injections. If the patients improve, I keep inject for a long time, following the protocol I, like 8 to 9 injections the first year, and second year 3 or 4 injects, but keep inject for 4, 5 years, and this helped me a lot. But only with this, after 6 injections, if it has no response, I think to switch for Ozurdex and try to re-inject Ozurdex every 3 months, because after that, usually the Ozurdex does not work well. And then sometimes I go to vitrectomy too.
I agree. I'm sure Santosh must have, offered this, but somehow patient did not come for follow-up. The issue here, like you rightly said, is of metabolic control, a poor control, and for follow-up not so good. Yes, Giri, you wanted to
I would
take
like to add here.
I thought I'll just add one more point. That is, a patient has got nephropathy. I mean, creatinine is quite high, and that is again another very important risk factor for progression of diabetic retinopathy. And whenever we operate on these sort of patients, especially cataract surgery, I think we have to be very careful, because basically the chance of worsening is much faster, much quicker, and more rapid. So that's another important point. I like that point. He has looked into the hemoglobin. That's very important.
Yes.
Because many of these patients have associated anemia.
Yeah.
And that again is another very important factor for rapid worsening of diabetic retinopathy. Therefore, from a cataract surgeon point of view, when you're operating on some of these patients, I think all these investigations you must do pre-operatively, because it gives you a good idea as regards to what are all the metabolic anomalies that the patient has. And, the retinopathy may not look that aggressive before the cataract, but with all these metabolic parameters going haywire pre-operatively itself, post-operatively, there is a rapid worsening.
Any other comment?
Yes, one point just wanted. Sorry, to add one more point here.
Yeah,
when you look at this, easy to say for us that patient is not following properly, but probably we need to understand patient may be going in and out of the hospital with all his systemic problem. Get admitted there, and that's why losing follow-up here. And if you have a obvious deranged parameter as far as nephropathy is concerned, rather I would wait for those parameters to come down. I won't mind waiting for a month or two before actively changing my treatment plan, because if those parameters, nephropathy comes under control, I think edema, macular edema sometimes just settles down on its own as well.
You see, the message for the anterior segment surgeons is that such patients require a very stringent follow-up, and no cataract surgery in moderate NPDR or should be done without OCT. They have to have the control and maximal drying effect on the retina before cataract surgery is undertaken. Otherwise, you see all this, visual improvement and negative effect of cataract surgery starts coming up. Now the problem is that patients started with 6.6 and 6.12, 6.18 and 6.12. Now is back to 6.12, 6.36, and ERM also is forming. So now issue is slightly more complicated issue now.
Dr. Lalit, it is all the more it says that these patients, we need to look at their metabolic status more often than we tend to do it. That's something, because this case, initially when he presented, he didn't have any nephropathy or anything. But somewhere along the line, he has been...
See, all of us keep saying about this, but believe me, whatever you say to the patient, whatever you stress, ultimately the practical real world scenario is a lot of these patients, unless and until, very few of them adhere, by and large, the control remains fluctuating up and down, and kidney issues and other issues start cropping. So we'll take one last comment from Dr. Avneet Gupta and move on to the third presentation, because Partho is not very happy with a lot of extensive discussion because he wants to move on. Yes, Avneet, final comment before I move on to the third case.
So one thing, giving steroids every 3 months, we have two glaucoma surgeons here, Dr. Amit and Dr. Jatinder. So if you start giving steroids, Ozurdex or IVTA, the incidence of glaucoma becomes pretty high. What Geneva trial says Dex implant should be given after 6 months. Even the company is recommending after 6 months. So what's your take?
It does not work for 6 months. I agree from one point. I agree with you that glaucoma, optic nerve analysis, and pressures we have to take into consideration. But 6 months Ozurdex does not work. It works for around 3 months or so. It does not work. So repeat injection required. But optic nerve health as well as the glaucoma consultations are required. In between that, I 100% agree with you. I think